Hello, ladies. Welcome back. In part one, we covered how statins work, the clinical evidence, which agents are available, the hydrophilic versus lipophilic distinction, and why timing your dose matters for short-acting statins. In part two today, we're going to tackle the questions that come up most often in clinical practice and that generate the most confusion. Do statins cause diabetes? How low should LDL actually go? What do you do when a statin alone isn't enough? And perhaps more importantly, what does the research actually say about statin side effects and muscle pain? That last one may change how you think about this entirely. Let's get into it. Let's start with a real concern that deserves a real answer. Statins do modestly increase the risk of developing type 2 diabetes. This is not a myth. The large meta-analyses show roughly a 10% increase in new onset diabetes with statin use. In absolute terms, for high-intensity statins in a moderate risk population, that translates to roughly one extra case of diabetes per 100 to 200 patients treated over 4 to 5 years. Who's at highest risk? Patients with pre-existing metabolic risk factors. Those who are overweight, have elevated fasting glucose, have high triglycerides, or who have the metabolic syndrome. In other words, these are people who were already on the road to diabetes. Statins appear to accelerate that progression in susceptible individuals. The mechanism likely involves reduced insulin secretion from the pancreatic beta cells and impaired glucose uptake in the skeletal muscle. So, should patients at risk for diabetes stop their statins? The guidelines are unambiguous here, and the logic is compelling. Diabetic patients have massively elevated cardiovascular risk. The leading cause of death in type 2 diabetes is cardiovascular disease. If statins slightly increase your risk of a condition whose primary killer is cardiovascular disease, but statins dramatically reduce cardiovascular disease, the math is not even close. You keep taking your statin. For every roughly 255 patients treated with high-intensity statins for 4 years, approximately one extra case of diabetes occurs. Over that same period, approximately 5 or more major cardiovascular events are prevented. The absolute clinical response to statin-associated diabetes risk is not to stop the statin, it's to intensify lifestyle interventions, to monitor glucose more closely, to manage diabetes if it happens. Diabetes is manageable. A heart attack, ladies, sometimes is not. So what are the LDL targets? Here, the question about how low LDL should go has evolved significantly, and the current answer is it depends entirely on your risk. A single LDL target for everyone is an outdated concept. The ACC-AHA framework stratifies patients by risk. At the highest tier, very high risk, we're talking about patients with established cardiovascular disease plus additional high-risk features. The LDL goal for these patients is below 55 milligrams per deciliter. The European guidelines go even further, below 40 for patients who have a second event within 2 years despite maximum therapy. High-risk patients, established ASCVD without additional high-risk features, should target below 70 milligrams per deciliter. Moderate risk primary prevention patients' target is below 100. The principle underlying all of this is that lower is better and there is no established lower limit of harm. Mendelian randomization studies looking at people genetically programmed to have very low LDL their entire lives show that lifelong low LDL is safe and beneficial. We have not found a floor below which LDL reduction becomes harmful. For primary prevention, risk estimation was just overhauled, and I mean just. The brand new 2026 ACC-AHA guideline on the management of dyslipidemia, published in March of this year, officially retired the pooled cohort equations that have been used since 2013 and replaced them with a new tool called the PREVENT equation. It's predicting risk of cardiovascular disease events. This is a meaningful upgrade. It's not a cosmetic one. The old pooled cohort equations were built on older, less diverse data sets and were known to overestimate 10-year cardiovascular risk by as much as 40 to 50% in certain populations. That mattered clinically. It meant that some lower risk patients were being recommended statins based on inflated risk estimates. The PREVENT model was developed using data from nearly 6 million contemporary US adults. It incorporates the traditional risk factors: age, sex, blood pressure, cholesterol, smoking, diabetes, but it also adds kidney function and GFR and optionally BMI and social risk factors. And critically, it generates both a 10-year and a 30-year cardiovascular risk estimate. That 30-year horizon is clinically powerful. Let's say I have a 42-year-old at my office whose 10-year prevent risk looks reassuringly low, but the 30-year number tells a different story. It gives me something concrete to anchor the conversation about lifestyle and earlier intervention. The new guidelines also introduce the CPR framework for primary prevention decisions. C for calculate the risk, P for personalize it with factors that the equation doesn't capture, and then R for recommend therapy in shared decision making with the patient. So what are those risk enhancing factors that push you towards more aggressive treatment even when the calculator gives a borderline number? So the 2026 guidelines formalize a comprehensive list, and for the first time, they give explicit prominent attention to reproductive and pregnancy-related history as independent cardiovascular risk markers. That matters enormously for how we approach women in primary prevention. Let's talk about women-specific risk enhancers from the 2026 guidelines. Preeclampsia is now formalized as a major cardiovascular risk enhancer. A woman who had preeclampsia during pregnancy has roughly double the lifetime risk of heart disease and stroke compared to a woman who had an uncomplicated pregnancy. This is not a small signal, yet for decades that obstetrics history sat at a different chart in a different specialty and never made it into the cardiovascular risk conversation. The 2026 guidelines explicitly say that it should. Gestational diabetes, even if resolved after delivery, is now recognized as a risk enhancer. Women who develop gestational diabetes have a significantly elevated lifetime risk of type 2 diabetes and cardiovascular disease. That pregnancy complication is a warning flare, that the metabolic system under stress didn't cope well, and it has long-term implications that go well beyond the delivery room. Preterm delivery, delivering before 37 weeks, particularly in the absence of obvious obstetric cause, is associated with increased maternal cardiovascular risk later in life. The placenta appears to be a metabolic stress test for the cardiovascular system, and preterm delivery may reflect underlying vascular dysfunction that predates the pregnancy. Early menopause, which is defined as menopause before the age of 40, whether it's natural or surgical, is a significant risk enhancer. Estrogen has protective effects on the vascular endothelium. Women who lose that protection early have an accelerated cardiovascular risk trajectory that PREVENT and other calculators don't fully account for. A 48-year-old woman who went through menopause at age 38 has a very different risk profile than one who had a natural transition at 52. And the 2026 guidelines is now saying explicitly you need to ask about it. Beyond the reproductive markers, the other risk enhancers formalized in the 2026 guidelines include family history of premature ASCVD, chronic inflammatory conditions like rheumatoid arthritis, lupus, psoriasis, HIV, chronic hepatitis, chronic kidney disease, metabolic syndrome, elevated lipoprotein A, which the 2026 guidelines now recommend measuring at least once in everyone. Elevated ApoB, high sensitivity CRP, elevated triglycerides. Other groups that have higher risk are the Filipinos and South Asians. Any of these should shift the clinical conversation toward more proactive treatment. And when there is still genuine uncertainty after accounting for all of those factors, coronary artery calcium scoring remains the tiebreaker. The CAC score of 0 in a lower risk patient suggests you can reasonably unreasonably defer statins, a high score is a wake-up call that the calculator may be underestimating the actual burden of disease. The Prevent calculator is freely available through the American Heart Association's website and is being integrated into electronic health records. Sometimes statins alone aren't enough to get patients to their LDL goals. Sometimes patients can't tolerate full dose, high intensity statins. In both cases, we now have excellent options that work through entirely different mechanisms, allowing us to stack therapies for additive LDL lowering, and in many cases to use lower statin doses that are better tolerated while still hitting the target. The first add-on should almost always be ezetimibe. It works in the gut, specifically blocking the NPC1L1 transporter that absorbs cholesterol from the intestine. Alone, it lowers LDL by 15 to 20%. Combined with a statin, you get another 20 to 25 reduction on top of that. The Improve It trial showed this translated into a real reduction in cardiovascular events. And ezetimibe is now generic, $4 a month, minimal side effects. It should be the reflexive first add-on. For patients who need more firepower, particularly secondary prevention patients who can't reach LDL goals on statin plus ezetimibe, we now have PCSK9 inhibitors. PCSK9 is a protein that the liver secretes that targets LDL receptors for destruction. When you inhibit PCSK9, the LDL receptors are preserved and recycled back to the cell surface. So your liver pulls dramatically more LDL out of the bloodstream. Two monoclonal antibodies are available, evolocumab and alirocumab, given by subcutaneous injection every 2 to 4 weeks. They lower LDL by an additional 50 to 60% on top of statin therapy. The Fourier and Odyssey outcomes trials both showed significant reductions in major adverse cardiovascular events, or MACE. There's also inclisiran. It's an siRNA molecule that silences PCSK9 production in the liver, given only twice a year after loading. Comparable LDL lowering, dramatically better adherence. The newest oral option is bempedoic acid. It inhibits ATP citrate lyase, which is an enzyme upstream of HMG-CoA reductase in the cholesterol synthesis pathway. Here's the clinically elegant part. Bempedoic acid, it's a prodrug activated only by an enzyme that is found in the liver. It is not in the skeletal muscle. So that means it does not cause muscle side effects. For patients with statin-associated muscle symptoms who cannot tolerate any statin, bempedoic acid is a real alternative with proven outcomes. The CLEAR Outcomes trial, which was published in 2023, showed that bempedoic acid reduced major adverse cardiovascular events, or MACE, in statin-intolerant patients by 13%. It's available alone and in a fixed-dose combination with ezetimibe that can achieve meaningful LDL reduction entirely without a statin. There's one caveat: it raises uric acid, so it needs to be used with caution in patients who have gout. Now let's talk about true statin intolerance and what the nocebo effect is. Up to 20% of patients in real-world practice report stopping statins due to side effects, predominantly muscle aches and myalgias. This is a massive clinical problem because every patient who stops their statin prematurely is at elevated cardiovascular risk. True myopathy, which is significant muscle weakness with markedly elevated creatine kinase, or CK, is uncommon. Rhabdomyolysis, which is where your muscle breakdown is so severe it can lead to kidney failure, occurs in roughly 1 to 3 per 100,000 patient years. It's genuinely rare. But here's what the blinded clinical trial data consistently shows: the rate of muscle symptoms in statin-treated patients is almost identical to the placebo group. When you take the patient's expectation out of the equation, the signal largely disappears. The Samson trial was published in the New England Journal of Medicine in 2020, and it tested this directly. So researchers recruited patients who had previously stopped statins due to side effects, and they gave them a series of blinded bottles containing either atorvastatin or placebo in a crossover design. And the result was striking. Roughly 90% of the symptom burden that these patients attributed to statins was equally reproduced by placebo. Only about 10% was actually pharmacologically attributable to the drug. This is what we call the nocebo effect, the mirror image of the placebo effect. When you expect a medication to cause symptoms, your brain can generate real subjective symptoms, not because of the drug, but because of the expectation. And in the case of statins, there is a powerful cultural narrative about muscle side effects that primes patients before they even take their first pill. That is not to dismiss that minority of patients who have genuine pharmacological statin intolerance. It exists, it is real. Certain populations are at higher risk, like older patients, women, those who have hypothyroidism, those with specific genetic variants that affect hepatic statin transport. So when this transporter doesn't work efficiently, plasma statin concentrations are higher and muscle exposure increases. But true statin intolerance, which is defined as inability to tolerate any statin at any dose despite systematic re-challenge, probably affects fewer than 5% of patients. The vast majority labeled statin intolerant either have a nocebo response or intolerance to a specific statin at a specific dose, and that can be addressed. When a patient reports muscle symptoms on a statin, first we need to check thyroid function because hypothyroidism dramatically increases myopathy risk. Second, we need to ask the right questions about the symptoms themselves because the nature of the complaint guides us on what to do next. If the complaint is muscle aching or fatigue, typical myalgia, creatine kinase level is generally not required and will not change the management much either way. A normal CK does not rule out statin-associated muscle symptoms, and a mildly elevated CK in an active patient may reflect nothing more than baseline variation or recent exercise. You don't need a number to validate what the patient is telling you. CK becomes important when the clinical picture escalates beyond simple myalgia, specifically when you are worried about myositis or rhabdomyolysis. The red flags that should prompt CK are significant muscle weakness rather than just aching symptoms that are severe or rapidly worsening. Dark or cola-colored urine that would suggest myoglobinuria, or complaints that are frankly out of proportion to a typical muscle ache. At that point, CK matters. Greater than 4 times the upper limit of normal suggests myositis, and greater than 10 times, especially with renal impairment or dark urine, raises concern for rhabdomyolysis. And that is when we stop the statin immediately and the patient needs further evaluation. For the much more common scenario, a patient with mild to moderate muscle aching and no red flags, the management pathway is we review the drug interactions, then we try a different statin, especially switching from a lipophilic to a hydrophilic agent. We can try a lower dose. We can try every other day dosing. Rosuvastatin works well this way because it has a long half-life. We can try a brief statin holiday and then re-challenge. And if genuine intolerance persists, bempedoic acid plus ezetimibe is now a proven alternative with cardiovascular outcomes data. One final point, how do we introduce statins to a patient matters. Research shows that how clinicians present side effect information influences whether the patients experience those effects. Emphasizing cardiovascular benefit first, presenting risk in absolute terms, using neutral rather than alarming language. That's what doctors should do. It's not a soft skill, it is medicine. To close out both talks, here are the 6 things I would like you to remember. 1, statins inhibit HMC-CoA reductase. The evidence that this reduces MI, stroke, and mortality is among the strongest in medicine. 2, most statins are now generic, $4 a month. There is no cost barrier. 3, hydrophilic statins are more liver selective and have a better muscle side effect profile. Short-acting statins belong at night. 4, statins modestly increase diabetes risk. The cardiovascular benefits so outweighs this that guidelines say to keep taking them, especially since diabetes itself kills primarily through cardiovascular disease. 5, LDL targets are risk-based. We have a powerful toolkit, Ezetimibe, PCSK9 inhibitors, bempedoic acid to get patients to goal, even when they cannot fully tolerate statin doses. 6, true statin intolerance is rare, under 5%. The nocebo effect is real. Systematic rechallenge, agent switching, and good communication with the patient can rescue most patients who believe they can't tolerate this life-saving medication. A heart attack prevented is someone who gets to be at their child's graduation or wedding. That is what we are talking about. Thank you.